Hi, hello everybody. Good evening to all of you. So, welcome to my session that is clinical respiratory physiology. And as you know, today we are going to discuss the part 2 of this topic because part 1 already been done in last Friday. So, this is the part 2. Now, before going into the session, I am just waiting for you to give me a nod whether I am visible and audible to you. Just give me a thumbs up or yes or no whether I am clearly audible and visible to you. Then we'll start the session. So anybody, just give me information that I am visible and audible to you. Right? Okay. So, in this session, what we are going to discuss, as you know, that MCQ, and along with the MCQ, some important core concept of the respiratory system that we are going to discuss here. Okay, so I'll put some question in front of you. First, you try to answer them, and then if answer is not possible or what is the theory behind the answer, that we'll discuss after your answer, right? So first question I'm putting in front of you. The question is, so the very famous and old question, okay, very famous. Why? Because this question has been asked multiple times in different exam preparation, so you must have seen this kind of curve. So here the question is, the pressure volume curve in this figure below were obtained from a normal subject and a patient. So from a normal subject curve and from a patient curve with a pulmonary disease, right? This is the only hint. Otherwise the curve is given and this is the patient curve and this is the normal curve. Now you have to tell me this patient is suffering from which of the following diseases, right? So now try to answer first. I'm not getting whether you are there in the chat box or not. Okay, so what will be the answer in this question? Anybody? So first of all, the curve which is given here, this curve is known as the compliance curve. This curve is known as the compliance curve. Why compliance curve? Because the curve is showing x-axis is the pressure change and y-axis is the volume change. That means this is the curve which is nothing but giving a relationship between volume change upon your pressure change. Means if you change a transpulmonary pressure, then what is going to happen? There will be change in volume. Right? Now I'm getting answer. Yes. So right. So this is nothing but a compliance curve, right? Exactly. So in this patient, I can find out that the compliance curve is above the normal curve. That means the patient have a, so I can infer from here that the patient have a high compliance than that of the normal curve. So if you now look at all of the diseases, then you must have known that this asbestosis, silicosis, tuberculosis, all of them comes under the heading of the restrictive lung diseases, because some of in all of these diseases there will be little kind of fibrosis deposition in the parenchymal tissue, right, Krishna? So that's why in case of emphysema, we all know that compliance increases, right? And because of the increase in compliance in emphysema, the answer here is nothing but emphysema, right? Now sometimes what extra can be given from this question is that you must have to remember that sometimes the y-axis different lung volume can be given, and in x-axis some pressure, maybe 2, maybe 4, this kind of pressure may be given. So in that cases, suppose this kind of curve is given and you have been asked to measure the compliance of the person who is suffering from emphysema, then you have to drop two perpendicular, one from suppose this level, and then you extend the perpendicular here, and then again you drop a perpendicular here, and from there you drop a perpendicular here. So suppose this pressure number is given 2, this is given 4, this is 6, like this, and suppose this is given around 800 and this is given 1400, right? So now I can easily calculate the compliance from the person. Why? Because now here the pressure change is 2 to 4. That means here in this question the delta P is nothing but 2, okay, and I can expect that with the change of pressure in this 2 millimeter of mercury or centimeter of water, there is change of volume. How much volume? From 800 to 1400. That means around 600 volume change has been occurred. 600 ml volume change has been occurred. So this is my delta V. So if this is in millimeter of mercury, so if you change a 2 millimeter of mercury pressure, there is change of 600 ml of lung volume. So if I put into this formula, then this is nothing but 600 upon 2. So this is 300 ml per 300 ml per millimeter of mercury. This will be the compliance of this person who is suffering from emphysema here, right? So please remember that this kind of curve can also be given for calculating the compliance also, right? So very simple question. This is very simple question. Now why I have put this question? Because I want, please don't make mistake in this kind of question. This is a very simple question, but don't make mistake, silly mistake in examination. Now second question I am going. Second question is related to the similar type of question. Now here the question, look at, try to answer. The question is asking, the following may reduce the FEV1 in a patient who is suffering from chronic obstructive pulmonary disease. So if you think of chronic obstructive pulmonary disease, emphysema comes in your mind, or maybe asthma also, or maybe bronchitis also. Now here it is asking which of the following reduces the FEV1. Which of the following reduces the FEV1? So you try to answer among all of this option. You try to answer what will be your answer. So this is easy question. So emphysema patient, why there is increase, which of the following will causes increase in FEV1? Oh, sorry, reduce in FEV1. Reduce in FEV1, right? Which of the following will reduce in FEV1, right? Okay. Very good. Go on. Try some answer. Go on. Okay. Anybody else? So in previous question also we have seen that emphysema patient, why the compliance is raised, okay, why the compliance is increased in case of emphysema patient. You know, compliance means the expansibility of the lung, that is the stretchability of the lung. So suppose I have made this alveoli. Now before going into the detailed discussion, first of all answer will be here is nothing but the C, and C. That is the loss of radial traction on airway. This is the cause which will causes, no, it is not the increased elastic recoiling of the lung. I'll explain. Okay, increased elastic recoiling is not possible in case of emphysema patient. There will be decrease in elastic recoiling in case of emphysema patient, and that is the major pathology of emphysema. So now look at, so suppose this is a normal alveoli. We all know that normal alveoli would be surrounded by these elastic tissues, and this elastic tissues has a recoiling tendency that is in the inward direction. So this is known as the elastic recoiling of the lung. So this elastic tissue which is surrounding the alveoli, these elastic tissue are also connected with the visceral pleura. This is also connected with the visceral pleura by some interconnecting septa. So these are nothing but the elastic septum. So this is a normal person. Means if I want to expand this alveoli, suppose I want to expand this alveoli, right? What will happen? This elastic tissue, because they are trying to recoil in the inward direction, they will prevent my expansion. They will prevent my stretchability. So I can say like this, that this elastic tissue, if it is very, very strong or if it is very, very hard, then what will happen to the expansion of the lung? Expansion of the lung will be less. Expansion of the lung less means the volume change of the lung is less. That means I can say, whenever you are trying to expanding this alveoli, during the expansion of this alveoli, there are some opposing force. One of these opposing forces here that we have just now discussed, that is nothing but the elastic recoiling of the lung. And second opposing force is also there, that is nothing but the surface tension of the lung, surface tension of this alveoli. They also act in the inward direction. So the surface tension of the alveoli as well as this elastic recoiling, both of them are opposing the expansion. Opposing the expansion means it is reducing your volume change, it is reducing your compliance. That means I can easily understand that if there is destruction of this, if there is destruction of this elastic tissue component, or if there is decrease in surface tension, in both of the cases, what will happen? There will be increase in compliance. So I can say like this, that destruction of this elastic tissue, what is going to happen? There will be increased expansion or increased volume change for the same amount of pressure change. That means there will be high compliance will be high. So this is the first important thing that you have to understand, that compliance high means the lung is loose, because it has lost the elastic tissue. So when this destruction of the elastic tissue is going to happen, this can happen normally in case of process of aging, means in case of aged person, the elastic tissue automatically destroyed. So this elastic septum, this elastic tissue will be automatically destroyed. But in case of emphysema, you know that the basic pathology is that because of the air trapping phenomena, inside the alveoli, what is going to happen? Alveolar size is going to increase more and more, and ultimately one point will reach where some of the alveoli is going to be ruptured like this, and whenever the alveoli is ruptured, along with that elastic tissue is also ruptured. So this is the basic pathology of emphysema patient. This is the basic pathology of emphysema patient, that there is destruction of the elastic tissue, because of which what is going to happen? There will be less elastic recoiling force. So now if I go back to the question once again, then I can easily understand that increased elastic recoiling of the lung is not going to happen in case of chronic obstructive pulmonary disease. There will be decreased elastic recoiling of the lung. Okay, but C option is saying that loss of radial traction on the airway. Okay, obviously if there is destruction of this elastic tissue, then there will be loss of radial traction of this airway. But how that is going to decrease your FEV1? That you have to explain also, because otherwise you are not understanding the pathology of emphysema. So first of all, what I told that there is destruction of the elastic tissue, because of which there will be decrease in the elastic recoiling force, not increase. So increase is the wrong word here. But because of the decrease in elastic tissue, I can understand that there will be loss of radial traction on the airway. So this radial traction, this is elastic septum, which are nothing but the traction on this airway, traction on this alveoli. Okay, they are lost. But how this loss of radial traction is going to reduce your FEV1? That is the basic thing. Okay, so whenever this elastic tissue is damaged, now one important phenomenon you have to understand. Now suppose the person is going to expire with a huge amount of force. So the person is suffering from emphysema and the person is trying to forceful expiration. So now he is doing a forceful expiration. Whenever the person is doing a forceful expiration, he will apply some extra force from the chest wall. So this is the force which is coming from the chest wall. Now suppose the chest wall force which is coming from the chest wall is nothing but 25 millimeter of mercury. This is an arbitrary number. I am taking this for understanding purpose only. So 25 force is applying from the chest wall, and the elastic recoiling force is 0. Elastic recoiling force is 0 in this alveoli because the alveoli is destroyed. So what will happen? The net force or the total force which will be applied on this alveoli is nothing but the force which is applying from the chest wall. With this 25 millimeter of mercury force, when the air is going out of this alveoli, what will happen? This pressure will drop. This pressure will drop gradually. Okay, so this 25 pressure will drop to 24, they will be dropped to 23 and 22 gradually like this. Why the pressure is dropping? This pressure is dropping because of the resistance of the airway. So always this thing happens also in normal lung also, but in normal lung this elastic tissue is intact, and because of the elastic tissue intact, this elastic recoiling force will also help in expiration process. Getting my point? Suppose the person is a normal person, then what will happen? There will be huge amount of force in this alveoli because you are applying some force from the chest wall, plus there are some elastic recoiling force. But in case of emphysema patient, understand the basic pathology that elastic recoiling force is lost. So whenever the elastic recoiling force is lost, it is only the external pressure, which is helping in the process of expiration. But there is a problem. What is the problem? Whenever the pressure is exerted on all part of this lung and bronchioles, the pressure will suddenly drop because of the airway resistance. Now I can understand here the pressure inside this small size bronchiole is 24-23 millimeter of mercury, and the pressure which the person is applying from outside is 25 millimeter of mercury. So what is going to happen? So internal pressure is less and external pressure is high. So there will be immediate or early closure of this airway. There will be collapse. Okay, there will be collapse of this airway. This collapse will be very early stage of the expiration, and because of the early collapse, whenever the person is doing forceful expiration, what will happen to the FEV1? Obviously FEV1 is going to reduce. So now you again understand, this is very important, very interesting and very important. So what I told, if you are a normal person, suppose you are a normal person, don't forget this, very important. So normal person, you are doing a forceful expiration. So suppose you are exerting a external pressure of 25 millimeter of mercury, and there will be some elastic recoiling force. Suppose this elastic recoiling force is around 5 millimeter of mercury. So now in these cases, what is the total force inside this applied on this alveoli? That is 30. 25 from external, 5 be due to elastic tissue. So with this 30 pressure, again the air will go out of the lung, so you are going to expire, so air will go out and the pressure will drop. But here the pressure drop will be like this, so 28, maybe 29, maybe 27, maybe 26. So this is arbitrary number. So I can understand that outside pressure is still lower than that of the inside pressure. That means automatically the most of the air will go out of the lung, and then only there may be closure of the bronchioles. That is known as the dynamic compression of airway. So this is normal phenomena. This is happening in your lung also if you do a forceful expiration. Okay, but here your elastic recoiling force is helping for the expiration process. But in case of emphysema disease, what is going to happen? The alveoli, some of the alveoli are ruptured. Because of this, the elastic tissue component is also ruptured. So now whatever the external force you are giving from the chest wall, maybe 25, maybe 30, maybe whatever external force you are applying from the chest wall, same amount of force will be exerted on the alveoli because elastic recoiling force is almost nil. With this force, air will try to go out of this lung. Whenever the air is trying to go out of the lung, there will be sudden drop of pressure like this, 24, 23 like this. Now I can understand that outside pressure of these bronchioles is 25 millimeter of mercury, inside pressure is 24 millimeter of mercury. So what is going to happen? This is the point where there will be collapse, Because of this collapse, what is going to happen? The person has taken a huge amount of inspiration. Why huge amount of inspiration? Because just now we have discussed emphysema patient means compliance is high. What do you mean by high compliance? High compliance means during inspiration there will be huge expansion of the lung. So when the emphysema patient is taking inspiration, there will be very little problem because lungs are very loose. So because of the high compliance, the person is taking inspiration normally or easily. So huge amount of air has already entered into the alveoli, but during expiration process, just now we have discussed that there is early collapse. There is early collapse. So huge amount of air is entering, but this air is not able to go out of this lung. This phenomena is known as the air trapping phenomena. Because of this air trapping, what is going to happen? Gradually the total lung capacity of this person is going to increase over the years. There will be increase in residual volume over the years. Because of the increase in total lung capacity, because of the increase in residual volume, what will happen? The lung size will be more and more. Because of the increase in lung size, because of the expansion of alveoli, what will happen? This will again leads to rupture of alveoli, and whenever there is rupture of alveoli, again the same thing is going to happen, that it will leads to more collapsible lung. So that's why it will produce a vicious cycle. Whenever there is some kind of destruction of the alveoli, elastic tissue is destroyed, that is the initiation process. That initiation process will causes more air trapping. More air trapping causes more expansion of lung. More expansion will causes more rupture of alveoli. More rupture of alveoli will produce again more collapse. And this is the basic thing which is going to happen in case of emphysema. Because of this early collapse, what is going to happen? FEV1 and FVC both are going to be reduced in case of emphysema patient. Now you tell me whether you understood this explanation clearly or not. So this is the explanation of this question, that why loss of radial traction on the airway is going to reduce the FEV1 of the emphysema patient. That is the basic pathology. The destruction of the elastic tissue will increase the compliance, but it will causes collapse of the airway, and that collapse will be very early stage of expiration. That is the basic thing. Got it, everybody? This should be clear. This should be clear, because this is the thing which you have to understood. Okay. Tenso, you understood? Okay. Dr. Hani, you understood? Dr. Shubham, Madhuri, Sayed Ahmed, you have understood? Krishna, you all are there and you got it now? The concept of emphysema, how the destruction of the radial traction or elastic tissue is causing problem during expiration. The airway become more collapsible, because whenever you are getting more force, more collapsible airway, right? If you have any question, you can ask me, because this is one of the important thing. Now I am going to the next question. Right, very good, very good. Now next question. Now again similar type of explanation, but see the question. If a seated normal subject exhale to residual volume, so the person has exhaled to residual volume, so he is doing a forceful expiration, because if you want to go up to the level of residual volume, you have to do a forceful expiration. Now in this condition, which of the following statement is true? That they are asking, that the volume of gas remaining in the lung is more than half of the vital capacity. All small airways in the lung are closed at closing volume. Interpleural pressure exceeds alveolar pressure. The PCO2 of expired gas falls just below just before the end of expiration. Read all of this option. Try to answer. Let's see how you exclude the option. Right. Okay. So what is the concept of residual volume that they are asking here, and what is the concept of this closing volume? These two concepts I will discuss here. Closing volume, residual volume. Okay. Okay. So you try to answer. By the meantime, I am drawing some diagram. Okay, that's a smart one. C or D, right? Very good. Yes, you are absolutely correct. Between C and D, you have to choose. Between C and D, you have to choose one. Right? No, C is not the correct answer, because always remember, interpleural pressure, if it is exceed the alveolar pressure, then there will be full collapse of the alveoli. Then there will be full collapse of the alveoli. Like for example, normally resting condition, interpleural pressure is negative and alveolar pressure is 0, means interpleural pressure is less than alveolar pressure. If interpleural pressure becomes 0, then what happens? That is a simple pneumothorax. Whenever that happens, we know there will be collapse of the alveoli. So residual volume means it is not the collapse of the alveoli. It is a normal phenomenon. If you do a forceful expiration also, there will be also residual volume remain in the lung. But before the residual volume reaching, what will happen? The bronchioles will be closer. That I am going to give the explanation here. But always remember that this is not true. Interpleural pressure is always lesser than intra-alveolar pressure. Okay, so this is not true. This is also not true. You can easily answer. And all small airways in the lung are closed at the closing volume. This is also not true. So obviously our answer is this one, that PCO2 of the expired gas fall just before the end of expiration, right? So first of all, suppose this is the schematic diagram of the lung just I have drawn here, right? So now you can easily understand from here that the person is in upright posture. So this person is in upright posture, means either he is in the sitting posture or in the standing posture, upright posture. In upright posture, because of the effect of the gravity, you know, the larger size alveoli will be present at the apical region of the lung and smaller size will be present at the basal level of the lung. That you all know, I hope. There is an explanation also, but I am not going into the detail of this explanation, that why the alveoli are larger in apical region. That is due to more negative intrapleural pressure in upright posture. But whatever. So the person is in an upright posture. Apical alveoli are larger, basal alveoli are smaller. Then if I ask you, now please tell me that heart is pumping blood from this region. So all of you can easily answer that more blood flow will occur in which part of the lung, apex or base of the lung, in this upright posture. So the heart is pumping blood from this region, more blood will flow in which region? Obviously base region. That means I can understand that if this is the capillary which is supplying the apical alveoli, this capillary size will be smaller in diameter. So this is the capillary. But the capillary which is supplying the blood in the basal area, the diameter will be more. So more blood will be base. Fine. Now I am asking you, please tell me that carbon dioxide tension is more in apical alveoli or basal alveoli? This is my question. I am giving you time for thinking. Why I am discussing all of this thing? Because everything is linked. Now if you try to understand that carbon dioxide is more in which type of, exactly, VQ ratio is more at the base. No, VQ ratio is more at the apex. So if you look at the apex VQ ratio here is 3.3, okay, and VQ ratio here is 0.6, okay. So VQ ratio is always maximum at the apical region of alveoli, Now you tell me carbon dioxide concentration or partial pressure is more in which region of alveoli? Okay, so two things you have to remember. Yes, it is the apical, it is the basal region. It is the basal region. Why? Yes, Shubham is correct. Why? Because why I am drawing this capillary and all, why I am taking your time? Because I want you to understand that what is the source of carbon dioxide in the alveoli. Where from the carbon dioxide will come inside this alveoli? If this is my alveoli, where from the carbon dioxide is coming to the alveoli? Very, very basic question. Where from the carbon dioxide is coming to the alveoli? That is nothing but the venous blood which is entering in this. This is nothing from the venous blood which is entering in this capillary. Now if the venous blood flow is less, obviously less amount of carbon dioxide is going to enter here, and if the venous blood flow is more, then more carbon dioxide is going to enter in this alveoli, right? Plus at the apical alveoli, ventilation is more than perfusion, means whatever carbon dioxide is reaching in this alveoli, it is less, and that carbon dioxide will be easily washed out from this lung. Why? Because here the ventilation is more than perfusion. If your ventilation is out of proportion to perfusion, that means you are going to wash out the carbon dioxide. So simple thing, the apical alveoli means the supply of carbon dioxide is less in that alveoli. Supply is wrong term, but for understanding. Plus this less amount of carbon dioxide is easily washed out from the lung, because in apical alveoli ventilation is more than perfusion, right? On the other hand, at the basal alveoli, the blood is coming more, so it is delivering more carbon dioxide to the alveoli. But here the VQ ratio is 0.6, means ventilation is lesser than perfusion. Means whatever carbon dioxide is delivered by the perfusion, that carbon dioxide is not going to easily wash out from this lung. That means basal alveoli will have more carbon dioxide tension. You got this concept? So if I ask you, in an upright posture, carbon dioxide tension is more in which alveoli? Basal alveoli. The opposite thing will occur in oxygen. Oxygen tension is high in apical alveoli, and oxygen tension is low in the basal alveoli. So just opposite. So at the level of apex, because the ventilation is more, PO2 is high and PCO2 is low. Just opposite will happen in case of basal alveoli. So base of the alveoli means PO2 will be low and PCO2 will be high. This we have probably discussed in my last class also, that with the help of this ventilation perfusion ratio. So I hope you understood this thing. In YouTube, your response comes a little later, so I am not understanding whether you get this thing or not. Otherwise, this is one of the important concepts, so I hope you get this thing. Up to this level you got this thing, right? Okay, so now I am deleting this diagram part. Okay, now second thing. Now you are doing a forceful expiration. So now I am drawing the same type of diagram. So this is apical alveoli, this is middle part alveoli, this is basal alveoli. Now what I am going to do, now the person is doing a forceful expiration. So oxygen should be higher at the base. No, oxygen should be higher at the apex, because I'm not understanding. Ventilation perfusion ratio is more in the apex. What do you mean by this? This means more ventilation but proportionate perfusion is less. If the ventilation is more, then more fresh air is going to enter in the alveoli. More fresh air means more oxygen. But carbon dioxide is less, because carbon dioxide is not coming from the ventilation. Carbon dioxide is coming from the blood circulation. So two things you have to remember, at least these two basic things. Okay, that oxygen is coming from the fresh air. Alveoli में oxygen कहाँ से आ रहा है? From the fresh air. So if the ventilation is out of proportion to perfusion, then oxygen will be higher. And where from the carbon dioxide is coming to the alveoli? Think like this. It is coming from the perfusion. If the perfusion is less, then less carbon dioxide will reach there. That is the basic thing. Now you got tensio. Okay, now you got this thing. So at the apical alveoli, oxygen is high, carbon dioxide is low. At the basal alveoli, oxygen is low, carbon dioxide is high. Now it is okay? Now it is okay? Now you have to understand second thing. Right. Now the person is doing a forceful expiration. Okay. Now you imagine yourself, the person is doing a forceful expiration. So whenever the person is doing a forceful expiration, what is going to happen? All of this alveolar size is going to be reduced. So this alveolar size is going to be reduced. This size is also going to reduce. This is also going to be reduced. And because of the reduction of this alveolar size, what is going to happen? The air which is present in this apical alveoli, this is going out. The middle part of alveoli, that is also going out, and the basal alveoli, that is also going out. But I can understand from here that whenever the more and more air is going out of the lung because of this forceful breathing, what is happening? The bronchiolar diameter as well as the diameter of this alveoli is reducing gradually. So all three alveoli, apical level alveoli, middle part alveoli, basal level alveoli, all three alveoli is getting their size reduced, and bronchiolar diameter is also reducing gradually. So if I maintain this forceful expiration, maintain the forceful expiration, I am not releasing the expiration, I am maintaining the forceful expiration like this, like this. So what will happen? One point will reach where this diameter of these basal bronchioles will be so less that it will be collapse. it will be collapse. Normal phenomena. Then when the basal alveoli collapse, after that there will be middle part alveoli collapse, after that there will be apical alveoli collapse. Why so? Think of yourself. If I ask you, among these three alveoli, which alveoli or which bronchioles is going to be collapsed earlier? Obvious thing, the basal alveoli size are smaller, so bronchiolar size are also smaller, because of which whenever you are doing a forceful expiration, the whole lung is getting compressed. So what is happening? The basal alveoli size is reducing, the middle part alveolar size is reducing, the apical alveolar size is also reducing. Then what will happen? One point will reach where the basal alveoli will be collapsed first. Okay, basal alveoli, I should not say the alveoli, basal bronchioles should collapse first. Okay, so this is one. Then the middle part bronchioles will be collapsed, then the apical bronchioles will be collapsed. When all of these bronchioles are closed off, when all of these bronchioles are closed off, so I am writing here, when all alveoli are closed off due to closure of the bronchioles, the remaining volume of air which is present in this alveoli, in this alveoli and in this alveoli, the remaining volume of air which is present in all of these alveoli, this is nothing but my residual volume. This is nothing but my residual volume. Getting my point? So why the residual volume never goes out of the lung? This is the explanation, that how can it go out of the lung? If you put more pressure from outside, there will be more collapse of these bronchioles, because they are already in a collapse state. Why the bronchiolar collapse is going on? This is due to dynamic compression of the airway, which we have discussed in the earlier question also, that whenever you are doing a forceful expiration, there will be compression of the alveoli, there will be compression of the bronchioles, and one point will reach where the basal alveoli will be closed off first, then the middle part alveoli will be closed off, then the apical alveoli will be closed off. So if I ask you, closure is starting at which region of the lung first? Obvious answer is that closure is starting at the base of the lung. So now the second definition, the volume which is present in the lung when only the basal alveoli are closed, when only the basal alveoli are closed off, but apical and middle part alveoli are still open. In this condition, so what is the condition? Condition is that this alveoli is still open, this alveoli is still open, but this basal alveoli are only closed off. In this condition, the remaining volume which is present here also, which is present in this alveoli also, which is present in this alveoli, this is known as the closing capacity of the lung. This is known as the closing capacity of the lung. Getting my point? So whenever I am doing a forceful expiration, imagine like this, you are doing a forceful expiration. So you have taken a deep inspiration. So suppose this is pyranometer recording, you have taken a deep inspiration. Now you are doing a forceful expiration going on. One point will reach where only the basal alveoli are closed off. In this condition, the remaining volume which is present inside your lung, this is known as the closing capacity. But if you maintain this forceful expiration some more time, one point will again reach where all of the alveoli are closed from basal, middle part and apical. All alveoli are closed. In this condition, the remaining volume which is present inside your lung is nothing but the residual volume. So means I can say from this that residual volume is always lesser than that of the closing capacity. Generally, whenever you are describing closing capacity, it is said that closing capacity is equal to residual volume plus closing volume. That means I can understand that this part is nothing but the closing volume. So if you add up this closing volume and residual volume, you are going to get the closing CT. So what is the bottom line from here? Bottom line is nothing but whenever you are doing a forceful expiration, the closure of the alveoli will be start from the base, then the middle part, then the apical part. So again you think of very important concept. So I am a person, I am a normal person, I am doing a forceful expiration. Whenever I am doing a forceful expiration, what is going to happen? There will be first closure at the basal alveoli. So basal alveoli are closed. Still my middle part alveoli and still my apical alveoli, sir, is closing capacity and FRC same? Obviously not. I'm going there. Just hold on. So just let me explain this, then I'm coming there. Okay, so always the closing capacity is lesser than FRC. Okay, but when the age advances or if there is pathology, it will be more than that. I'm going there in the second diagram, but hold on. So what I'm saying, so whenever you are doing a forceful expiration, look at this maneuver. What is going to happen? If you continue the forceful expiration, one point will reach where only the basal alveoli are closed off, right? Then in this condition, the volume which is remaining here and here, that is closing capacity. Now if you maintain this forceful expiration for some more time, some more air will come out from this middle part alveoli, some more air will come out from this apical alveoli, and then there will be closure of this middle part alveoli, there will be closure of this apical alveoli. When all of these alveoli are closed, already the basal is closed, now the middle is also closed, the apical is also closed. In this condition, the remaining volume which is present here, they are known as the residual volume. So first one is the closing capacity, and now this is the residual volume. Getting my point? So I can understand from this discussion now that during the forceful expiration, when the basal alveoli are closed, that is the remaining volume which is present is known as the closing capacity. After the closing capacity, the air, so basal alveoli are closed, now you have reached to the closing capacity. Now I know that if I maintain the forceful expiration, air will come out from which level of alveoli? The middle part and mainly the apical part. Getting my point? After you reach the closing capacity, the air which is come out to the exterior is coming from apical alveoli mainly, some part may also coming from the middle part. Now if the air is coming from the apical part of the alveoli, then what will happen to the carbon dioxide tension of this air? Tell me. So this is the forceful expiration and you have reached at the end of expiration, because after the expiration of this air, what is going to happen? All of this alveoli is going to be closed. So before the closure of all alveoli, that means before the reaching of this residual volume, the air which is coming out to the exterior, that is coming out from the apical most alveoli. Now you tell me, the air which is coming out from the apical most alveoli, what will happen to the carbon dioxide tension of this air? Low or high in comparison to other part of the lung? Everybody tell me, that we have already discussed. Recall and try to answer. The carbon dioxide tension of this apical air which is coming, that is less or more than other? That will be very low, because that we have already discussed that apical most alveoli means PCO2 is very low. Now you again look back at the question, very difficult question. The PCO2 of the expired gas falls just before the end of expiration. So if you do a forceful expiration just before the end of expiration, what is going to happen? Your partial pressure of carbon dioxide will suddenly fall. That means if you draw the carbon dioxide curve from the alveoli, initially there will be high, then there will be carbon dioxide rise. Suddenly the carbon dioxide will start falling. Whenever the carbon dioxide start falling means it indicates that now the basal alveoli are closed off. Now the air is coming from which type of alveoli? the apical alveoli the carbon dioxide is coming. So this is the explanation of this question, that pCO2 of the expired gas fall just before the end of expiration. Now you look at the other option. All small airways in the lung are closed as closing volume or closing capacity. All is the closing volume or closing capacity. Is this true? Obviously this is not a true statement. When all small airway in the lung are closed, then that volume is known as the residual volume. It is not the closing volume. Now you got it? Everybody tell me. Now I am coming back to your question. Okay, so what I told you, I have plotted this kind of curve. So if you look at the spirometer recording, so suppose this is my y-axis, clear everything. Suppose I am drawing a spirometer recording. So spirometer recording means inspiration, expiration, inspiration, expiration, like this. Then the person is taking a deep inspiration, so this is maximum inspiration. Then the person is doing a forceful expiration, so this is the maximum expiration, and this is the process. Now all of you know that the volume which is still remaining inside this lung is nothing but residual volume, and if you add up this expiratory reserve volume and this residual volume, this is nothing but my functional residual capacity, right? Now during the process of closing capacity discussion, we have discussed that if you maintain this forceful expiration, one point you will reach here, in between here, one point you are reaching here, where only the basal alveoli are closed off, and then you will reach a point where it is the point of residual volume, where all alveoli are closed off. All alveoli are closed off. So when only the basal alveoli are closed off, in this condition, the remaining air which is present in your lung, this is nothing but your closing capacity. So now you can easily understand that in a normal person, FRC is always greater than closing capacity. FRC is always greater than closing capacity. But when the age of the person increases, the FRC become almost equal to closing capacity at the age of 66 years. Or FRC can be very greater than closing capacity if the airways are highly collapsible. Airways are highly collapsible means even reaching up to this point, even before that, the airway are closing here. That is means highly collapsible airway, which is typically seen in case of hyaline membrane diseases because of huge amount of surface tension. Now you tell me whether you got this thing or not. Okay, so this is all about the discussion of the closing capacities and residual volume. What is the concept of this closing capacity and residual volume? Tell me everybody whether you understood this or not. Give me a thumbs up or give me a yes or something like that, so that I can understand that the time which I have taken for explaining this topic, you got this thing. Okay, right? So Madhuri has given a nod, thank you. So Krishna, Tensho, you have given just I'm waiting for your Tensho, you have given answer, right? Got it, very good. So all of you understood? If you have any question now, you can free to clarify your queries, right? Very good, very good. So please remember, only the basal alveoli closed, the remaining volume is closing capacities. All alveoli are closed off because of the bronchiolar collapse, due to dynamic compression. When all alveoli are closed off, that is the residual volume. That's why residual volume never goes out of the lung. That's why residual volume cannot be measured by spirometer. That's why we do not get any recording of residual volume in spirometer. That is the reason, right? Very good, very good. Now next question. Next question is a little difficult one. Next question is more difficult one, right? So okay, look at it. Try to answer. It may be hard, I'll explain, don't worry, right? So try to answer. A 32-year-old medical student has fourfold increase in cardiac output during strenuous exercise. So this is the clue. The person is doing strenuous exercise. Which curve on the figure below likely to represent the change in oxygen tension that occur as the blood flow from arterial end to venous end of pulmonary capillary. Remember, this is the pulmonary capillary. This arterial and venous end which is written here, this is the pulmonary capillary. Difficult one, I believe. Yes, difficult one. But so should I wait for your answer? You try to give some answer. You try, then I will answer. Right. Thinking, na? Yes, obviously. This is difficult question. This is tough question. Really tough. Don't understand question, sir. Yes. Actually, if you I'll make you understand. Okay, actually this is a different type of phenomena which we do not read normally, right? This is something related to transit time at the level of pulmonary capillary. Transit time. Okay, so now let's discuss. So first of all, answer is D, but this is no meaning. If I say answer is D curve, there is no meaning, so I must have to explain. So what is the explanation? So again the same thing, my famous alveoli. So again the same thing I am drawing. This is my famous alveoli, right? So below this alveoli I am drawing the pulmonary capillary. So this is my pulmonary capillary. So pulmonary capillary means from this side, this is the pulmonary artery. That means this is the arterial end of pulmonary capillary, and this is the pulmonary vein. Blood is flowing in this direction. So this is the venous end of pulmonary capillary, right? So I have to understand how the oxygen diffusion occur from this alveoli to the level of this capillary. So what is the partial pressure of oxygen at the level of alveoli? This is generally 100 or 104, okay, whatever way, 100 millimeter of mercury or 104 millimeter of mercury. What is the partial pressure of this oxygen? What is the partial pressure of oxygen in this pulmonary arterial blood? We know pulmonary arterial blood means the composition of this blood is venous blood. That means partial pressure of oxygen here is 40 millimeter of mercury. Now I have given everything. Now I am asking, tell me what is the difference of pressure between alveoli to pulmonary capillary. What is the average? What is the average difference of partial pressure of oxygen? Partial pressure of oxygen between this alveoli and capillary. Tell me. I want to listen. Answer is not here. Yes, I know you will give answer 60. Okay, everybody, is anything else you want to answer, or this is the same type of answer? So this is the average word. This is changing your MCQ. So suppose this is your MCQ. The average partial pressure difference between alveoli and pulmonary capillary for oxygen. The average partial pressure difference between alveoli and pulmonary capillary is how much? Answer is 11 millimeter of mercury. I am not saying, Guyton is saying, and there is explanation for this, but you must have to remember the average partial pressure difference between this alveoli and pulmonary capillary is 11 rather than 60. So question is, why 11, sir? I can easily understand, I can easily make out that this is 60, this is 100, this is 40, so difference is 60. But I am saying, yes, at the beginning of this pulmonary capillary the difference is 60, but whenever the oxygen is diffusing from this alveoli to the capillary, what will happen to the partial pressure of oxygen in this capillary? It will rise. Whenever the partial pressure in the capillary is rising, what will happen to the difference? Obviously, the difference of partial pressure from this alveoli to the capillary is going to be reduced gradually. It is going to be reduced gradually. That means if it is 60, it will be 50 somewhere here, it will be 40 somewhere here, it will be 30 somewhere here, and one point will reach where there will be no partial pressure difference between these two zones. No partial pressure difference means partial pressure at the level of this capillary is also 100, partial pressure at the level of alveoli is also 100. If the difference of partial pressure is 0, then no diffusion of gas is going to happen. That means I can understand that the diffusion of oxygen from this alveoli to the capillary is not going to continue throughout this capillary, Why? Because one point will reach where the partial pressure of oxygen in the capillary is same to same with the partial pressure at the level of alveoli, and when this thing is happening, there will be no diffusion. There is no diffusion. Getting my point? Now I am asking, I will come to this point again. Now I am asking, so can you say that the difference of partial pressure between alveoli and capillary is always 60? Can you say that average difference is 60? Answer is never, because the difference is only 60 at the beginning. After that the difference will decrease. So if I have to measure the average difference of partial pressure between these two spaces, I can understand that the difference is not same to same at every point of capillary. So I have to take a integrated value of pressure, P dt. What is T? T is the total time in which, it is the total time T. So this is 0 point and this is the T point. This is the total time when the blood is traveling through this pulmonary capillary. So this is the total time which the blood is taking to cross the pulmonary capillary. So if I now take that from this 0 up to this T point, the pressure difference P with respect to dt, that is the integrated pressure, this will be around 11 millimeter of mercury. This will not be 60, because 60 is at the beginning, but pressure is dropping continuously. Because of the drop of pressure, if the question is what is the average partial pressure difference between this alveoli and capillary, answer is 11 millimeter of mercury. First of all, you tell me you got this gist or not. If you don't understand this, then I cannot go to the second part. You got this thing or not? First you tell me, everybody. Right? You got this thing? Okay. Tell me whether you got this thing or not. You have to take the integrated pressure, and it is clearly written in guidance that integrated pressure difference between these two is nothing but, this is nothing but 11 millimeter of mercury. Now, second I am discussing the time which is taken by this blood to cross this pulmonary artery, this time which the blood is taking to cross this pulmonary artery, this is known as the transit time at the level of pulmonary capillary. This is known as the transit time of blood at the level of pulmonary capillary. So if the question is how much time the blood or the RBC is remaining at the level of pulmonary capillary, your answer will be this is nothing but transit time, and this is 0.75 second. This can be a future MCQ. Please remember, this is nothing but 0.75 seconds, right? Now my question, when the oxygen diffusion is occurring, how much time it is taking for diffusion equilibrium to reach? What do you mean by diffusion equilibrium? Now it is a different question. Now I'm asking diffusion equilibrium is reached at which time point? Do you think it is taking whole 0.75 second for diffusion equilibrium to reach? Means I am asking, this is 100, when this 100 millimeter of mercury pressure will reach, at how much time point? Do you think all of this 0.75 taken is required? Answer is never. Exactly, very good, Krishna. So diffusion equilibrium is reached only 1/3 of transit time, that means this is 0.25 second time is only required. Diffusion equilibrium will be reached in 0.25 seconds. So I can understand like that oxygen diffusion is very good at the level of lung. Why so? Why are you saying, sir? I am saying so because initially the oxygen is entering here, then the oxygen is entering here, then the oxygen is entering here. When the blood or when the RBC is just reached up to 1/3 of this pulmonary capillary, the diffusion is complete. When the blood or the RBC has traveled only 1/3 of the pulmonary capillary, means In rest of the time there will be no diffusion at all. So this is a reserve portion, there is no diffusion at all. Now I want to plot this diffusion of oxygen with the help of a curve. Now it will become very simplified. So now x-axis is time. What is this time? This time is nothing but transit time. So this is 0.25, this is 0.5, and this is 0.75. You have understood what I mean to say. And this y-axis, this is nothing but partial pressure of oxygen, right? So now you think of when the oxygen, when the venous blood is entering at the level of this arterial end of the pulmonary capillary, what is the partial pressure of oxygen? 40. So suppose this is my 40 millimeter of mercury partial pressure of oxygen, means the blood has just entered into the pulmonary capillary. Then whenever the blood is moving in this direction through this transit time, what is going to happen? I just understood that suddenly within this 0.15 second, within this 0.25 second, the diffusion equilibrium will reach. Diffusion equilibrium means the partial pressure of the capillary blood will be 100. That means if I plot this curve, the curve will looks like this, that initially when it is entering at the level of pulmonary capillary 40, suddenly within this 0.25 second, the partial pressure of oxygen has rose up to 100 millimeter of mercury, and then throughout this transit time the partial pressure of oxygen is remaining same to same. Getting my point? The partial pressure of oxygen is remaining same to same. So I can understand the diffusion of oxygen is very good. Within 0.25 second the diffusion is complete. Then if I want to increase the diffusion of oxygen, then there is no way, because already the diffusion equilibrium has reached. Diffusion equilibrium means partial pressure same to same ho chuka hai already. You cannot increase the diffusion. You can increase the diffusion of oxygen only by increasing the blood flow rate through this pulmonary capillary. Look at what I am saying. If you change the perfusion through this pulmonary capillary, now what will happen? If you increase the perfusion through this pulmonary capillary, then more rapid blood is coming. What will happen to transit time when the velocity of the blood increases? What will happen to transit time when the velocity of blood is increases, or more volume of blood is rising, more volume of blood is coming? What will happen to transit time? It will be decrease. That means only way to increase the diffusion or amount of oxygen diffusion is by increasing the amount of perfusion of blood. Yes, that's why this diffusion of oxygen is known as, this is known as perfusion limited gas diffusion. That perfusion is a limiting factor. If you change the perfusion, then you can increase the diffusion amount of oxygen. Otherwise, initially the diffusion of oxygen is so good that diffusion equilibrium has reached. You cannot give more oxygen will be transferred to the capillary because the diffusion equilibrium has already reached. So only way to increase the diffusion of oxygen by increasing the perfusion or increasing the flow of blood. On the other hand, if you think of carbon monoxide, what is the speciality of this carbon monoxide gas? We know carbon monoxide gas, it 250 times higher affinity for hemoglobin. That means whenever the carbon monoxide enter from alveoli to blood, it will combine with hemoglobin. Now always remember, if the gas is combining with hemoglobin, then what will happen to partial pressure? Partial pressure is 0. Because what is partial pressure of gas? This is the basic concept. Partial pressure of gas is nothing but the given by the partial pressure of gas is exerted by the dissolved portion of the gas. If the gas is combining with hemoglobin, then it will not exert partial pressure. So for oxygen, partial pressure, there will be some dissolved portion, there will be some hemoglobin bound portion, and that dissolved oxygen is responsible for partial pressure of oxygen. But if I give carbon monoxide, so now I am understanding that if the carbon monoxide is present here, and whenever the carbon monoxide is transported from this alveoli to the level of capillary, what will happen to the partial pressure of carbon monoxide in this capillary blood? Near equal to 0, because all the carbon monoxide is going to be combined with the hemoglobin. So in this curve, if I plot a carbon monoxide diffusion curve, so carbon monoxide means in venous blood, what is the carbon monoxide partial pressure? 0. So this is, I am starting from here. Okay, then when the carbon monoxide is going through this pulmonary capillary, what will happen to the partial pressure of carbon monoxide in capillary blood? It will remain almost same to same. This is the carbon monoxide diffusion curve. That means in case of carbon monoxide diffusion, do you think the diffusion equilibrium has reached? Answer is no. Diffusion equilibrium has not reached yet. That means there is huge space for transport of more carbon monoxide if you give it at the level of alveoli. That means if I want to increase the diffusion of carbon monoxide, what I can increase? I can increase the more amount of gas. More amount of gas means more will be transported at the level of capillary, because the diffusion equilibrium has not reached. That's why the carbon monoxide diffusion is known as diffusion limited gas. This is known as the diffusion limited gas. Now on the other hand, if you give nitrous oxide, right? So what is nitrous oxide? You know that nitrous oxide is an inert gas. Not only nitrous oxide, any kind of inert gas means if it is not combining with hemoglobin at all. It is not combining with hemoglobin at all. That is the meaning of the inert gas. So if you give inert gas, look at how the diffusion curve will look like. So whenever the inert gas, nitric oxide, will enter at the level of capillary, it is not going to combine with hemoglobin. So all nitrous oxide which has been transferred at the level of blood will remain in the dissolved portion. If it is remain in the dissolved portion, what will happen to the partial pressure of this nitrous oxide? It will be very, very huge. That means for nitrous oxide, the diffusion equilibrium will reach more earlier even than that of the oxygen, because for nitrous oxide there is only and only dissolve. Nitrous oxide meal, there is only and only dissolve, but for oxygen there is dissolve, there is hemoglobin bound also. Because the nitrous oxide contain only and only dissolved portion, whenever the nitrous oxide is entering in the blood, huge amount of partial pressure rise will occur, and then there will be immediately there will be diffusion equilibrium reach. It is said that for nitrous oxide, this equilibrium will be reached in 1/10 of the total transit time. 1/10. For oxygen, it is 1/3. For nitrous oxide, this is only 1/10. Now you tell me, you got this thing or not? This is the exact thing which is given in this curve. This is the exact thing which has been given in your question, right? Now got this thing, everybody tell me, this is the exact thing. Okay, right? So now I am dividing this thing. So this is my arterial end, this is my venous end. That means this is the total transit time. So total transit time means this is the 1/3, this is the 2/3, this is the complete transit time. So this is the 1/3. So now looking at this curve, tell me which curve is oxygen diffusion curve. Which curve is oxygen diffusion curve? Tell me from this normal oxygen diffusion curve. Everybody tell me the answer. Which curve is normal oxygen diffusion curve? A, B or C? What do you think? Which curve is normal oxygen diffusion curve? Oxygen diffusion is complete or diffusion equilibrium is complete in 1/3 of the time period. So if I had to choose only one curve from these two, then yes, exactly, very good. Now you are understanding. The B curve is the oxygen diffusion curve. The A curve may be of type of inert gases curve. We do not know, maybe it nitrous oxide, but even in nitrous oxide it has to reach to 0. It is not starting from 40. So look at here. Exactly. Now all of you are giving correct answer. So look at here. So it has started from 40 millimeter of mercury, because partial pressure of oxygen in the arterial end, that is the venous blood partial pressure of oxygen, and here it has reached up to 100 millimeter of mercury. So this curve is nothing but the oxygen curve. Now I'm asking you, tell me what about this C curve? C curve means, what do you think? The similar kind of oxygen diffusion, yes, from 40 to 100, yes, correct, everybody correct. Now you tell me, think of this curve C. You can understand from this C curve that here the transit time has been reduced. Transit time 1/3 from the venous end, yes, 1/3 from the venous end, 1/3 of the total transit time, 1/3 from the venous end. No, not from this venous end, means venous blood end, means arterial end. From here, this is the direction where the blood is going. This is the 1/3 time. Within this time, the oxygen diffusion will be completed. Within this time, the oxygen diffusion will be completed. Now look at the curve C. C curve is the thing where the transit time has been decreased. That means I can say C curve is a curve where the T has been reduced. Why the T has been reduced? Maybe due to, for example, suppose there is increase in heart rate. Due to increase in heart rate, okay, so heart rate has increased, so more blood, or the blood is flowing through the pulmonary capillary in a rapid manner. So what will happen? The transit time will be decreased. So transit time decrease means, if the transit time decreased to 1/3 of the total time, transit time was normally 0.75, now suppose it has reduced to 0.25 second. So obvious thing is that the diffusion equilibrium require at least 0.25 second. So when the transit time is less, the diffusion equilibrium will not reach initially. It will take some more time for equilibrium to reach, and equilibrium will reach at the end of this venous end. Getting my point? Getting the understanding? You have to think of this thing, that if the blood is flowing in a rapid manner, when the heart rate is high, then your transit time is reduced. Transit time reduced means still also, even if the transit time is reduced also, then also diffusion equilibrium for oxygen will be reached, but it will be reached at the end of this pulmonary capillary, because the time has been reduced, the total time has been reduced. Now, none of this my answer. B, C is not my answer. A may be of nitrous oxide curve. Now, when the person is doing exercise, why the C curve is not the answer? Because we know that during exercise also heart rate increases. But during exercise, because the muscle is consuming more oxygen, muscle oxygen consumption is more. Okay, muscle is consuming more oxygen. So what will happen to the venous blood oxygen? If the muscle is consuming more oxygen from the arterial blood, what is going to happen to the venous blood oxygen? Venous blood oxygen partial pressure will be lesser than normal. But arterial partial pressure of oxygen, exactly, that is the clue here. That, Parag, you are very correct, that venous blood oxygen partial pressure will be low, but arterial blood partial pressure will not be lower, because whatever extra amount has been taken up by the muscle, that will be compensated at the level of lung. That's why arterial blood partial pressure of oxygen, PO2 in the arterial blood will remain normal, but venous blood partial pressure of oxygen will be less. So only one curve I can find out from here, that the venous blood partial pressure is less than normal. So it is 40, it is less than that. Only one curve. And again, because of the increase in heart rate during exercise, again the equilibrium is reaching at the late stage, and that is reaching at the end of the capillary, at the end of the pulmonary capillary. That's why the curve which is indicating that the person is doing exercise, from this discussion, so from this discussion I can easily understand that the curve which is my answer is nothing but my D, D and D. Got it, everybody? So this is a very, very difficult type of question, but now I hope everybody understood this concept. Okay, clear to all of you? Please let me know if you have any question or queries, because we are going to finish up this session. Okay, right, so we'll discuss the remaining question in the next topic. So now, because the time is over, so I'm finishing the session. So if you have any queries, you can free to ask. Okay, Thank you so much for joining me, and thank you so much for understanding. Now this is just for the promotion purpose that I have taken this capsule course on CNS physiology. Exactly, anxiety, fever, where the oxygen consumption in the muscle is not very high, but the diffusion, the transit time is less, or it can also occur suppose the diffusion amount is reduced due to fibrosis of the lung. Then also it will take long time for diffusion to complete it. That can also happen in case of fibrosis also. Okay, so this is the thing that you have to remember. Very exactly. Okay, exactly, anxiety C curve. Yes, correct. Okay, so now this is for the promotion purpose, the capsule course on CNS physiology and the capsule course on endocrine physiology, that too I have already taken. Now currently I am taking the capsule course on respiratory physiology, but that is a paid course. If you are planning to join the paid course in the Unacademy platform, then please use my code, that is Dr. Soumen 10 for 10% discount. And also I am a part of this batch course. This is the batch course which is who are targeting this NEET 2022 examination, right? So here the physiology will be taught in 84 hours. So total duration of physiology is 84 hours, huge amount of duration. So I will discuss the detail of the physiology in this batch course. So if you are planning to join this batch course, again please use my code. So these are the different faculty who are also part of this team along with me, and these are the different time duration and the class duration that has been detail given. So you can pause the video and you can go through the detail. And if you want to subscribe, this is the different amount of subscription. Okay, and these are the few upcoming course that you can join in Unacademy Learner app. This is not in YouTube session, these are the Unacademy Learner app, and this is the Unacademy YouTube channel. Please subscribe this channel so you'll get the different update about the different class by faculty. Okay, so this is all about for today. Thank you so much for listening. Good night, take care, bye. So this is